You are listening to Death and Sparkling Wine podcast, conversations about hope and hopelessness. Our host is Johanna Perttilä, who is a therapist, educator and a supervisor from Finland. She also works with cancer patients and their families.
Welcome, Harvey Max Chochinov. You are a highly educated professor, and before we go to your professional status, I would like to ask, what should we know about you as a person?
This is a very good question, and you know this question because some of my work has talked about the patient dignity question. What should I know about you as a person to take the best care of you that I can? I guess you should know that I'm a psychiatrist. I was born and raised in Winnipeg, Canada. Most of my education took place in Winnipeg. I am, I think, third generation Canadian. So it was my great grandfather who were amongst the first immigrants in our family to come to this country, and I've been raised here. My children have been raised here. I spent some time getting educated outside of Canada. I did a fellowship in psychiatric oncology at Memorial Sloan Kettering Cancer Center, and that really provided me a wonderful foundation to be able to do this kind of work. I suppose on a more personal front, I'm married with 2 children, recently became a grandfather for the first time.
Wow.
And so those are some of the personal and special things happening in my life outside of the professional realm, which we will, of course, be talking about.
Congratulations about your first grandchild.
Thank you.
So, let's talk about your professional status. What should we know about these things?
As a psychiatrist, I began working in the area of psychiatry and oncology going back, more than 35 years. As I said, I did a fellowship at Memorial Sloan Kettering, which is a very large North American cancer center, came back to Canada and began doing clinical work in this area, seeing patients with cancer and their families. And then about 5 years into my career, I became interested in research. And the research has all been in the area of palliative care. And I've spent really the entirety of my career exploring what I refer to as the experiential landscape of end-of-life care. So we have studied things like depression, anxiety, desire for death, will to live, quality of life, spirituality, and as you know, have also conducted a large program of research on the area of dignity. And the research on dignity has been really fascinating because it's given us insights into understanding some of the struggles that patients near the end of life confront. Feeling like personhood, for example, is under assault. And what we can do possibly as healthcare providers to try and maintain a sense for patients that they continue to be themselves, that they are more than their physical illness. So that in a very brief way is what I've been engaged in over the course of my research career.
Mm. You mentioned dignity therapy or dignity research. Tell me about that.
Well, the work on dignity actually emerged from the observation that in the Benelux countries, there were some early studies that reported what they called the prevalence of MDEL, or medical decisions to end life. And as it turns out, amongst Dutch patients, about 4%, at the time this study was published, which is, in the early 1990s, about 4% of Dutch patients were dying as a result of euthanasia. so the lethal injection of medication causing their death, and less than 0.5% were dying as a result of assisted suicide. So they were given a prescription for a drug that they can take at overdose to hasten their death. But the really interesting part of the study was the why. And Paul Vandermaas, who was the lead author, went back to the death record of all of these patients who had died as a result of a hastened death, and he identified the physician who was involved and approached them to say, why do you think your patient sought out a hastened death? And this was really intriguing. And of course, as a psychiatrist, trying to understand the emotional dimensions of why people want to live or why people don't want to live was extraordinary, because here was this profound window of understanding from doctors who had been there with patients who had in fact sought out their assistance to die. And the findings that emerged from that put dignity on my radar, because more so than any other reason, these Dutch physicians said it was a loss of dignity that led their patient to seek a hastened death. So we thought, well, if dignity is worth dying for, then dignity is worth studying. And we began to do the first studies on dignity in the context of approaching end of life. And that research, and the reason that we started to do this research, and the reason really that I think one does research in palliative care, is to give us a better handle of understanding what patients are experiencing in order for us to be able to provide better care. I mean, this is not just an empty intellectual endeavor. This is meant to have a practical outcome, that we should be better positioned to look after people who are living with life-threatening and life-limiting illness. And the work on dignity really delivered on that. So perhaps we could talk about, some of the findings. One of the early findings from the dignity research was trying to understand what was most predictive of lost sense of dignity. So we know that many things might affect an individual's sense of dignity. Bad pain control, can undermine dignity. Lack of adequate support from family or friends or a healthcare system can be an assault on human dignity. Not having good psychological and spiritual support can undermine a person's sense of dignity. We discovered in one of our early studies is that the thing that most predicted sense of dignity in these patients was their perception for how they were seen. What I mean by that, because it was sort of an unexpected finding, but this issue of appearance was most predictive, how they felt they appeared to others. So this was really somewhat of an epiphany, because it said to me that, good palliative care, or even good medical care really, is not just about what we are doing to the patients, but it's also our way of being with the patients. And I actually wrote a separate article that I published. The original article, our findings were published in The Lancet, and then a separate article was published in the Journal of Clinical Oncology. And in that article, I called that article Dignity and the Eye of the Beholder. And even though it's based on empirical evidence, what I try and put forth in that article is that metaphorically, patients are looking in the eye of the healthcare provider for a reflection that will affirm their sense of dignity. In other words, we want to be seen for the totality of who we are. If people just see a problem checklist, if they just see a differential diagnosis, then patienthood has eclipsed personhood. But if there's acknowledgement of who you are as an individual, then you're more likely to maintain your sense of dignity. So that was amongst the earliest studies that we reported on dignity in the terminally ill.
You talk about practical ways among dignity. Do you have some practical way? What should every healthcare provider do, or what are your examples?
So the first thing I would say in terms of practical, although it may sound kind of ephemeral, is the awareness that your gaze, the way you are with patients, your disposition, your attitude, is going to shape their healthcare experience. Now, somebody listening to this, or a healthcare provider listening to this may say, I don't buy that. My work is to go in, to make the right diagnosis, to give the right drug, to cut out the right tumor, to do those things that, I think of as transactional. And those are all critically important. But the evidence says that your disposition, your attitude, the reflection that patients see in your eye is going to profoundly shape the healthcare experience. So that is one practical piece of advice, to be mindful that how you are with patients matters. I wrote an article years ago that it was called "The Secret Is Out, Patients Are People with Feelings That Matter." Mm-hmm. So the practical take-home message is, remember it, because if you don't provide that kind of affirming gaze, people suffer. And there's been much written about suffering and the fact that suffering is experienced by persons when they feel their essence is under assault or in danger of disintegration. So that would be the first practical thing, is to be mindful of your disposition and influence that you have in the presence of others. The second practical implication is when we studied dignity, we also were able to look at all of the variables that might have an influence on dignity. And eventually, we actually published an outcome measure called the Patient Dignity Inventory. It consists of 25 items. It covers a broad spectrum from the physical, the psychological, spiritual, existential, everything from are you in pain to I no longer feel like I'm the person I once was. So if you're thinking about providing dignity-conserving care, the Patient Dignity Inventory can give you practical insights on what might reinforce or what might undermine a patient's sense of dignity. You can either, use the instrument, which is available online. It's free. It's in the public domain, and it's being translated into multiple languages. Or you can look at the Patient Dignity Inventory to just make yourself aware of the multitude of variables that you need to be mindful of. Again, people often talk about, that, preservation of dignity is part of what we do. It's part of our mandate. It's part of our values. And those words are easy to say, but I think knowing that dignity means different things to different people and understanding the variables that we have identified that can reinforce it or undermine it gives you a practical way of saying, well, if I'm going to practice dignity-conserving care, I better be familiar with what I have published and called, the model of dignity in the terminally ill. It's an empirical model that gives you all of these variables. So that would be the second practical issue. That talking about dignity is not just a philosophical issue. It's not just a values issue that, you put on a placard and, hang on a wall in a hospital or on an elevator in a healthcare facility. You need to know what are the constituents of dignity in order to practice dignity-conserving care. I suppose well, there are two others. that come to mind. One is what I call the patient dignity question. the question you asked me at the outset. So we have discovered, I mean, if the reflection in the eye of the healthcare provider is important, what it means is that personhood matters. You know, it's important to know not just the illness I have, but it's important to know at least the essence of who I am as a human being. So the patient dignity question is a simple way of putting personhood on our radar. And as you know, Johanna, from having, read some of my literature, the patient dignity question reads, what do I need to know about you as a person to take the best care of you possible? Now, that is meant to be the stem of a conversation. The conversation usually takes anywhere from as little as 5 minutes, on average 10, no more than 15 minutes. It focuses on who are you as a person, and specifically, how would you want people to appreciate who you are as a human being, when you are lying in this bed or when you're here in this healthcare facility. And we know, because we've all been patients, it's irritating when you feel like you're just being processed as another patient. It's a great irony. We spend our entire professional lives learning how to look after patients, and what you learn from the work is, at the end of the day, no one likes to feel like just another patient. Because patient is generic. It's based on objective criterion that put us in a silo of being a heart patient or a kidney patient or a lung patient or a psychiatric patient. No one likes to feel siloed in that way because it's generic and it reduces us to something that is lesser than who we are and the totality of our being. So the patient dignity question is a way of saying to everyone, how would you want to be seen? What do you want us to understand of who you are as a personhood, who you are as a person? We listen to those conversations. We summarize them. We summarize them into a couple of paragraphs. In our studies, we have come back to read that to the patient, give them an opportunity to make any editorial changes, and then the litmus test, do you want this placed on your medical chart? Do you want this as part of your record? And in my experience, I have never had a single patient, nor have I ever had a single family, because families can do this by proxy if the patient is no longer able to speak on their own behalf. I have never had a patient or family who has said no. Everyone says, this needs to be on the chart. And we have now published literature on this, and there have now been other people around the world who have done investigations on this. There are thousands of patients who've been reported on who have availed themselves of the patient dignity question. And the results are really quite extraordinary. We know that patients say this matters. Their families say it matters. They say it could change the way they are seen. It could change the way they are cared for. They recommend it for almost 100% recommend it for other patients or families in this situation. From the other side of the ledger, the healthcare providers, they say 90% of the times they learn something they didn't previously know. It heightens sense of connectedness, empathy, respect, and it also heightens job satisfaction. So knowing something about the patient, not just dealing with the patient in a robotic way, in a very kind of technical and mechanical way, but dealing with them in a very human way, increases job satisfaction. And I would say that's important because that also will protect people who deliver healthcare from vulnerabilities around professional burnout.
This is so important. What do you think? Should these things be only in palliative care?
So dignity therapy is something we haven't spoken about. Dignity therapy is a brief psychological intervention that we have developed. It was initially developed specifically for palliative care, and we have trained therapists around the world to learn how to elicit conversations from patients who are approaching end of life so they can create a legacy. And these conversations are transcribed, they're recorded, they're given back to the patient so they can share with the people who matter. And those documents can then speak on that person's behalf, even in a way that will transcend death. Dignity therapy is now the most studied psychological intervention in palliative care. Over 100 papers in the literature, over, I think, 12 systematic reviews, all of which show the ways in which it can enhance end-of-life experience, reduce depression, anxiety, enhance quality of life, enhance a sense of meaning and purpose and connectedness. Over the last couple of decades, dignity therapy has also begun to be used in non-palliative circumstances. So people who are earlier in their disease, people who may not be imminently dying, but, a frail elderly, for example, or people whose personhood is under assault. People who, for example, may have early cognitive decline, or people who are incarcerated, people who are dying in prison settings. Dignity therapy is being used in all of those circumstances, and people who are mentally ill. But your question also reminds me that when it comes to things like the patient dignity question, acknowledging personhood, practicing kindness, compassion, understanding, palliative care doesn't have a monopoly on the importance of those things. Those things matter from cradle to grave. And so what I've noticed, happening in the literature, and it's gratifying to see, is that the patient dignity question, at least the approach around the importance of personhood, is finding its ways beyond palliative care and into contemporary medicine kind of writ large.
Let's talk about ABCD model. What should we know about this model?
When I was a few years into this work, I got an invitation from the British Medical Journal to try and summarize some of my work, and the message as we were developing, or as I was developing this manuscript, is to try and make it practical. That, it's too easy to become kind of esoteric and philosophical about issues that are as seemingly ephemeral as dignity. And so I began to think about, what are the practical things that all healthcare providers need to know in order to call themselves a physician or a nurse? And I thought about the ABCs of critical care. So every healthcare provider knows that, if a patient is unconscious and you come upon them, you should bear in mind the ABCs, clear the airway. Are they breathing? Circulation. Those are core efficiencies of working in healthcare. And no one is absolved from that responsibility. I mean, if I as a psychiatrist came upon such a patient and simply held their hand, looked in their eyes, and gave them professional empathy as they died, people would say, that's ridiculous. I mean, that is not good healthcare. And yet when it comes to the humanities of healthcare, we say there are no core efficiencies, or we just say, be a kind person, just do your best. And we know that not everybody practices medicine in a way that is uniformly kind or humane, or are they're at least not mindful that those are elements or things they're responsible for. So in the article that was eventually published in the British Medical Journal, I published on what I called the ABCDs of dignity conserving care. And what I said is that these are core efficiencies, not just of psychiatrists or psychologists or social worker or pastoral care professionals. These are core efficiencies for anyone working in healthcare, anyone who has contact with patients. So the A stands for attitude. We've already talked about that. Your attitude and disposition is going to shape every healthcare encounter for your patients. So you need to be mindful of that. B stands for behavior. Behavior that is informed by an understanding that your attitude makes a difference. So Do you sit at the bedside? Do you stand? Do you meet someone's gaze? Do you avert their gaze? Are you distracted by the 1,000 things that might take away your attention? Or if you've only got 5 minutes, in a mindful way, do you shut out the rest of the world and devote those 5 minutes solely and totally to that patient? And we know, by the way, there have been some lovely studies that have been done that show that even, for example, sitting versus standing, there was a study that was done in orthopedic surgery and found that if the orthopedic surgeon, it was a randomized control trial, sitting versus standing, if the orthopedic surgeon sat at the bedside at the first post-op visit with the patient, there was a 90% chance that the patient would be satisfied with the encounter, and the perception of the amount of time was 5 times longer than they were actually there, compared to the results they got when the physician was randomized to standing, where there wasn't this kind of distortion in perception of the passage of time, and level of satisfaction was somewhere in 40 to 50%. So B is for behavior. C is compassion. And compassion is the awareness of suffering of another person and the attempt to mitigate that suffering. And I underscore of another person because to provide compassionate care, you need to understand who that person is. And people, we hear all the time, that you are practicing person-centered care. I say, if you don't know the person, if you don't know the essence of the person, you are not practicing person-centered care. You may be practicing kind care, efficient care, best efforts care. You are not practicing person-centered care in the absence of knowing something about the person. And you can't provide compassionate care without being mindful of person and personhood. And finally, D is for dialogue. The conversations we have with patients. Those conversations can be as detailed as something like dignity therapy. I want to know all about you so we can create a legacy that you can then leave to your loved ones. That's fairly detailed. But in essence, the dialogue needs to be something about who is this individual. I think of an example. A number of years ago, I was entering into a door of a room, and adjacent to that door was the entry. It was a room where a medical oncologist, a very eminent colleague who was a specialist in hematology oncology, he and his patients were entering into their space for the appointment. And the last thing that I heard being said before he shut the door was, "So how was the vacation?" Mm. Then you might say, well, so what? It doesn't matter. The point is that leukemia doesn't take vacation, but people do. I guarantee you, within 3 minutes, they were no longer talking about the vacation. They didn't spend a half hour looking through photographs of the trip. But it's these simple things that we do to remind ourselves, as that article says, patients are people with feelings that matter. And so finding a way to put that on your radar. And the patient dignity question, what do I need to know about you as a person in order to take the best care of you possible, is at least one way of doing that. So the ABCDs of dignity conserving care are core efficiencies of everyone in healthcare. Your attitude matters, your behavior matters. Being a compassionate care provider, meaning also being attentive to understanding personhood, and dialogue. Conversations that acknowledge that you're not just dealing with a tumor, you're dealing with a whole person.
What are your thoughts about lack of time and these busy professionals at healthcare?
Everybody who works in healthcare is under a time crunch, or in most instances you find people under a time crunch. And I guess, that's one of the realities of large healthcare systems, large volumes of patients, and trying to meet, your patient's needs is having to a limited amount of time that is available. So my response, though, is the following. First off, we know that large healthcare systems work at, and we perseverate on efficiency, trying to make the encounters as efficient as possible. And I guess, and that's understandable and it's laudable, but if people feel that they are essentially on a healthcare assembly line, then we begin to feel, or people begin to feel, that they are under some kind of an emotional or existential assault. If this, assembly lines work well, if you're dealing with automobiles, for example. Automobiles are made of platinum and steel. And so they do very well in that way. But people are not made of platinum and steel. And so if we're not attentive to the human dimension of their experience, then people feel somehow that they have not been seen. They've not been heard. As I say, it doesn't take, if you have a limited amount of time, then be mindful of using that time in a way that is completely focused on that individual without being distracted, because that will give them the message, even in this moment, I am here with you. I am seeing you. Now, the other thing as far as time, I think, is the question, can we afford, so you're saying, can we afford to do this? And my question is, well, can we afford not to do this? Because if we don't do this, first of all, patients aren't going to be as trusting. There's going to be a higher discordance in goals of care. Patients are more likely to complain if they don't feel, and the reason that patients complain, and you can go to any patient representative working in a healthcare facility around the world, in 90% of instances, it's something around communication. People just didn't feel treated well. It wasn't a medical error. I mean, those happened in a rare instances, and they're tragic, but they're the minority. Usually, the reason that people complain is because they felt they were treated just like another patient. And there's something diminishing about this. There's something kind of emotionally abrasive about that. So, and the chances of a healthcare provider being sued are heightened by a practice that isn't mindful of the human dimension of care. So there's also reputational capital and possibilities of litigation. The final thing, when I think about, well, can you afford not to do this? When healthcare becomes so focused on the transactional as opposed to the relational, the things that we have to do to the patients, then people become emotionally disengaged. They kind of are acting in a robotic way. And that places healthcare professionals at risk of professional burnout. And so those are the reasons why I say, I understand the challenge, but I'm not sure that we can afford not to do this. Because if we don't do this, everyone pays the price. The patient pays the price because they feel assaulted. The family pays the price because they feel that their loved one has been diminished to a status that they're not deserving of. And the healthcare individual has to become more robotic and more removed from the pathos of what's happening, and healthcare systems risk their reputational capital. Sounds to me like a high-risk endeavor.
What is platinum rule? How it is different of golden rule?
When we discovered that the healthcare provider gaze was important, in other words, how you see your patient affects their care. So I began to think, well, what shapes our gaze? We know that intuitively, when we are with a patient or a family, or even in life in general, when we're trying to figure out what might be in the best interest of someone else, what would be the best thing to do in this circumstance, we oftentimes, intuitively use ourselves as a gauge. And that is the golden rule. So if I were in this situation, what would I want done? Do unto others as you would have others do unto you. Makes good sense. And it's an important kind of moral adage that you see in religious traditions across millennia. But it does mean that we are using this external barometer, if you will, to gauge what a patient might want. And what happens when our lived experience is very different than the person that we're seeing? You know, what if our values, our outlook, our experience has taken a very different pathway? And so this is acknowledging the fact that each of our lens has been shaped in the way that we have been raised, in the way we've been socialized, what we've been taught has value or has lesser value. And, I mean, that's not a criticism of who we are. It is just an acknowledgement of the human condition. You know, our outlook is shaped by the life course that we've lived up until this point of time. So what happens in situations, and I published one paper on this where I talked about an elderly, a gentleman who had a head and neck malignancy, and his healthcare provider said, you know, things may not go well. And not now, but at some point, if things really go terribly, you may want to consider medical assistance in dying. Now, the article really was looking at, well, what shapes the gaze of that individual? I mean, the patient, as it turned out, had absolutely no interest in a hastened death. That was just not on his radar. It was not part of his values. It was not part of his outlook, the way he anticipated he would approach end of life. But what shapes the gaze of the healthcare provider? And in part, could it be trying to guide the patient down a road that the healthcare provider, he himself, would find intolerable? You know, I mean, so might it be that he was looking at this and saying, you know, gee, I don't know I don't know that I would want to be that disabled or that old or perhaps that disenfranchised or that marginal, whatever the issue is, but clearly his gaze was shaped by something that was divergent from the gaze of the patient. And so the platinum rule then says not just doing to the patient as you would want done unto yourself, but doing unto patients as they would want done unto themselves. In other words, the most important and critical perspective is not how we see things. The most critical, important perspective is how the patient sees things. And just as a practical example, in palliative care, we practice what I would call a platinum standard when it comes to a situation where the patient can no longer speak on their behalf. So it's not an uncommon scenario to find yourself in a room, if you're working in palliative care, where the patient, is no longer able to voice their wishes or desires. And the question to the wife or the husband or the son or daughter or child is not what would you want us to do for your father, mother, brother, sister. Not what would you want us to do in this instance, but if we could bring them back into this room the way they were a month ago, what is it that they would want done? That is a platinum standard. And that, in my estimation, is raising the bar on person-centered care. The other thing, and certainly here in North America, there is a lot of discussion about what we call EDI, equity, diversity, inclusiveness. It's a big part of conversations in medicine. And I would say, if we're interested in that discourse, then the platinum rule, at least awareness that our perceptions shape experience in these profound ways, and dealing with prejudicial issues or dealing with the issue of bias or unconscious bias, that, to my way of thinking, is an important element of understanding EDI, or equity, diversity, inclusiveness.
This podcast name is in Finnish, kuolemaa ja kuohuviiniä, and it means death and sparkling wine. What What do you think about that?
Well, I think for the first time in my life, I might really consider wanting to become Finnish. I mean, it sounds like a marvelous way of kind of thinking about these issues, because for many people, I mean, the issue of death and dying is frightening, and in some instances, it's even forbidden. You know, the idea that if we talk about it, it's too painful. I remember talking about this with one friend who was very aversive to conversations about death, and she said, you know, I don't want to talk about it. It's too painful. It upsets me too much, and I worry that if I talk about it somehow, you know, I'm tempting fate. And I try to reassure that, look, I promise you, no matter how much we talk about this, this is not going to change the time clock on your eventual death by a nanosecond. But the other nice thing about, you know, the title, you know, about, you know, death and sparkling wine is it says that it is not only okay, but it is important to talk about these things in a way that is going to make us feel less frightened, more prepared, and that preparation and that those conversations will eventually down the road have very practical implications. I mean, we live our lives in ways in which we so much value personal autonomy, the idea that we make decisions about our life. Having these conversations, the kind of conversations you and I are having today, or families sitting down and having these conversations, it allows you to extend that autonomy to your final breath. Because it says at some point in time, well, you had the wherewithal and the good health and were mindful, you were able to say, you know, I think this is what would be important to me. I think this is what would matter. And so I say, you know, yeah, death and sparkling wine. Let's talk about it. Let's talk about it because talking about it matters, and matters in a way that will allow us to continue to be who we are to the very end.
Tell me about your newest book.
So my newest book is called Dignity and Care, The Human Side of Medicine. It just recently came out in paperback, which I'm pleased about because the price point I'm hoping will make it much more accessible to audiences internationally. And when I talk about audience, I'm really talking about anybody who's interested in the issue of the human side of medicine, and anybody certainly who is working within the area of healthcare. And I think of that in very broad ways. If you are in a situation where you have contact with patients, then being mindful of the human side of medicine is important to you. So it tries to summarize all of the research that I've done on this, tries to underscore many of the points we've made in this conversation, and also illustrates them with scores of stories that things I've experienced or colleagues of mine who are very sensitive and empathic and know how to practice the human side of medicine, so that it feels like something that is accessible and again feels practical. It's not just sort of the theory of this, but it really illustrates by way of stories and examples how this can be done. The other thing, and again, sort of related to our conversation about death and sparkling wine, I realized that I'm currently healthy. I am not old, but certainly I am in the third act of my life, of my career. And when I wrote this book, it was very much with the thought in mind, it is time to pull together much of what I've learned and to try and put it in a way that will make it accessible to patients, to anybody who eventually will be a patient, and to healthcare providers, and to anybody having contact with people who are encountering the need to be within healthcare.
Wow, I must order your book. Our last episode we had pharmacist here, and he wanted to ask you about what are the best ways to meet and communicate those people who are soon to die or someone who has just lost his loved one. What are the main principles?
I would say, one of the things that I've written about is something that I call intensive caring. It's an article that was published in the Journal of Clinical Oncology, and it really tries to outline our way of being with people who are suffering. Dame Cicely Saunders was the founder of the modern hospice movement, and one of the famous expressions of Dame Cicely was, "You matter because you are you, and you matter to the end of your life." And I wrote the article on intensive caring thinking, well, how can we provide care that helps people understand that they still matter? And so that article on intensive caring outlines various ways in which healthcare providers can enter into this care and not feel as helpless, not feel nihilistic, understanding that there are some really important therapeutic tools. So one of the tools, and getting back to your pharmacist question, was, so how can you be with people who are dying, or how can you be with people who have experienced a recent loss? The few things that, there's much to be said about it, but I guess a few take-home messages are, one, don't worry about and don't put on yourself this idea of finding the right thing to say. That is not helpful. What is helpful is showing up and understanding that being with people is the thing that will make them feel that they matter. Not some platitude like, well, don't worry, or it's all going to be okay, or for the person who's now suffered a loss, well, at least they're not suffering, or, it's God's will. These are well-intentioned, but they're not helpful. What's helpful, if you think about, our human design, we have 2 ears and 1 mouth. There's a clue in that. Listen, be present, and don't worry about, having to say the right thing. The most helpful thing you can say is, geez, I'm really sorry this is happening. And that's probably, that is helpful. Anything beyond that, you could be taking a risk of putting your foot in your mouth. But if you're listening, trying to understand, being present and attentive, that is powerful. So the other thing that, and I've kind of described that is as, what I would call therapeutic presence. It is a way of being with people that's not about what you're saying, it's not about what you're doing, it's simply being there, attentive, caring, empathic. The other thing that I've written about in that article on intensive caring is what I call therapeutic humility. So, those of us who work in medicine, we're very attracted to the idea that we're going to go in and we're going to fix stuff. I'll examine you, I'll diagnose what's wrong with you, and I'll fix it. It's a very seductive model. It's why most of us go into medicine. But what most of us come to realize is that there are elements of human experience that defy being fixed. That doesn't mean that we withdraw. What it means is that we show up, but we have therapeutic humility. We understand that fixing is not part of the menu. It's that it's not always available. So showing up, avoiding the need to fix, being humble, not placing that expectation on yourself. So I think that if you can walk into those encounters, at least with those kind of core insights, you are going to find yourself feeling much less helpless and much more effective. Now somebody listening to this may say, well, you know, that sounds really touchy-feely. That sounds really kind of soft. I'm not sure how profound this advice really is. Well, to put it in context, there was a study that was done, and there have been a number of studies that have affirmed this, but this is just one study that a number of years ago that was done amongst young patients with advanced cancers. And the thing that was most predictive of suicidality in this cohort of patients with advanced disease was the strength of the connection with their healthcare provider, even more so than psychotropic medication. And so the reason that I cite that study is because it says that presence, showing up, being connected, that more so than anything else was predictive of suicidality in these young people with really bad disease. So if you're thinking for a moment, you know, showing up, so what? You know, does that really matter? Is that going to make a difference? Well, if you think there's a difference between wanting to live and not wanting to live, then I would say the difference is profound, then showing up can make an exquisite difference in the life of somebody who may be living with a life-threatening and life-limiting condition.
Our next episode guest is going to be my colleague, Ulla, and she works at Cancer Society as a psychotherapist. And she meets cancer patients and their loved ones, and also staff at the hospitals, nurses and doctors. What you would want to ask about Ulla?
You know, I mean, oftentimes people who do this work, there is this balance between being overly emotionally connected with your patient and, you know, placing yourself at risk of feeling overwhelmed, and the opposite spectrum of, you know, being emotionally disconnected. And of course, then you become less effective therapeutically. So I'm wondering if she could talk about this kind of empathic dance and the relationship between empathic distance and being therapeutically effective.
Wow, very interesting. Empathic dance, I love it. Hope in hopeless times in medical situations. What do you think about that?
Hope is an interesting construct, and for most of our lives we think of hope, and hope is kind of based on the expectation of what the future will hold. And yet, what we have found in our studies is that even patients whose medical prognosis is hopeless very rarely endorse hopelessness. So even people whose prognosis is beyond cure very rarely say that they are hopeless or feel hopeless. So it's one of the times in life when hope really uncouples from the expectation of time and really becomes about meaning and purpose. So I would say that even in patients who are terminally ill, it's not unrealistic to have conversations about hope, which is about hope in finding meaning, purpose in what today is going to bring. The other thing I would say is that, you know, it's really helpful. I mean, if you're being therapeutically, if you're engaged with a patient, for at least one person in the room not to feel hopeless. And sometimes, you know, the therapist has to be mindful of the possibilities that are still available to that person, you know, the things that even with death pending, life still holds in store. Even, you know, for some patients, knowing that what they are doing is modeling how the people who are bearing witness to their death will eventually face their own. We need to be aware that hope and holding on to hope is important if we're going to engage with patients in a way that is not going to somehow collude with their hopelessness, but is going to give them insights into what is still possible, even in the context of approaching death.
We have discussed many interesting and important things. Is there anything you would like to say to our listeners about all these things? Or have you something on your mind that we haven't talked about yet?
This past year, I gave a lecture to the incoming medical students. The Dean of Medicine asked me to give this lecture, and it's called the White Coat Ceremony. I don't know if there's an equivalent in European medical schools, but this has become an annual tradition of all medical schools where the students come into the class for the very first time, their families are invited, and they come up on stage and they're given their white coats. And I was asked to make the keynote address. And so I would say, a couple of things that I shared with them, and maybe a good place to close this conversation. One was, I asked them to aspire to be more than human body mechanics. I asked them to aspire to be healers. And the last thing that might be worth sharing with you, and something I shared with them, was this. Patients won't care what you know until they know that you care.
So, Harvey, what are your sparkling wine moments in Canada today?
This conversation with you.
Thank you.
It's been a wonderful vintage. We definitely have to think about coming back, revisiting, and having another sip.
Thank you so much.
It's been my pleasure. Thank you for the opportunity.
Death and Sparkling Wine podcast is provided by Johanna Perttilä and Dialogis Ltd.